everybody. Hello. I'll let everyone get settled here. It's so nice to see so many faces out this morning. My name is Brooke Mendelson. I will be your presenter this morning on this very, very high yield topic that I'm very happy to see so many of you are also so interested in this. So thank you for coming. Currently, I am a second year resident in the psychiatry program through St. Luke's. So I am almost halfway done with my journey, hopefully halfway done with my journey of being a full-blown psychiatrist. So that is my plan. Addiction, psychiatry, and medicine has always been close to my heart. Growing up, I am from Pennsylvania. I love Pennsylvania, from northeastern PA, so just a couple hours north of here. If you guys have ever heard of Scranton, of course, like The Office is the only thing I've ever gotten. Every time I leave Pennsylvania, that's all I get is, oh, like The Office, right? Yeah, sure. But there's a lot more in Pennsylvania than people know. And I think the Lehigh Valley is a wonderful place with so many resources, so many more than I ever experienced growing up in the small town of Factoryville, Pennsylvania. So I could talk a little bit more about myself. First person to actually go to college. So I'm very, very proud and very happy to be where I am right now. But I wouldn't be here without my best friend and my grandmother, who has struggled with her fight with addiction for many years. Growing up, I didn't quite understand what it meant, to go through this continuous fight that people never actually overcome fully. It's always there, I think. It's one of those things where it affects the people around them. And I went to AA meetings all the time growing up. Every Friday night I spent with my grandmother at an AA meeting, from being in a stroller as young as I can remember all the way up to my teenage years. So very close to my heart. I saw the community side and the support side of addiction growing up, and now I'm kind of seeing more of that clinical side. So I hope today we can kind of merge those two things together, and I can, talk a little bit about dual diagnosis and kind of that intersection between mental health and substance use disorders. Feel free, if anyone has any questions that are very pressing, you can raise my hand, or raise your hand, you can shout out to me, but I can take questions at the end too. All right, so getting started. Kind of just diving in a little bit with some facts. This is kind of how I like to set the tone, just so people kind of get an idea. We all know how prevalent both mental illness and substance use disorders are, and how prevalent both of those two intersect. But just a little bit on, the epidemiology of this, the statistics of it. We look and we see that 10.6% among adults in the US have some sort of substance use disorder. And that's, of course, a spectrum. And we'll get into the diagnosis and the criteria in a little bit. In the United States as well, 5.3% of individuals have alcohol use disorder, 3% with an illicit use disorder. And we know this. We see only a fraction of people in, the clinical, settings, and even in the community settings, whereas a minority receives that specialty care that they need. Like I said, comorbidity, very common. So 20 to 30% have substance use disorder and co-occurring psychiatric disorders. 40 to 60% in addiction treatment settings. So, if any of you work, with this population every single day, you will see it. You will see the prevalence of, depression, anxiety, bipolar. We've got everything, everything you can imagine. It does not discriminate mental illness as well as substance use disorders and addiction. So, of course, like I said, depression, anxiety, PTSD, bipolar, ADHD, those are the most common co-occurring psychiatric disorders that we see amongst these people with substance use disorder. And, the outcomes kind of worsen when you have two things happening at the same time. It kind of clouds the water a little bit, I would say. You don't know what's happening first, right? Was it, the depression that led to the self-medicating of the substances? Is it the substances worsening the depression? That's kind of where we have to try to figure that out and figure out what the best treatment is for these patients and people. And then, like I said, 46% of individuals with a mental or substance use disorder experience 2 or more diagnosable conditions, so 2 or more. So now we're not even just dealing with one thing, we're dealing with multiple. People with opioid use disorder, depression is about 36%, anxiety 29%, and PTSD 18%. And then, of course, our adolescents and our young adults are particularly vulnerable, with 75% presenting for substance use treatment. So looking at just addiction as a whole, I know that most presentations I've been to in this realm kind of go through a little bit of what even is this? Like, what happens in the brain? Because now we actually have, the clinical evidence that addiction and substance use disorders is a diagnosis. It is a chemical change. It is neuroplasticity that happens in our brain structures. So looking at kind of our activation of our reward system, that's what these substances do. So we work with dopamine in the brain mostly. It works in the nucleus accumbens, which is in our reward system, as well as the basal ganglia structures. I have a picture next to kind of make this make a little bit more sense. Over time, it causes neuroplastic changes. That just means structural changes in the brain after continuous exposure. So we have our glutaminergic and our dopaminergic pathways, which are different neurochemicals in our brain. And working in the prefrontal cortex, the limbic regions, the stratum, and like I said, the amygdala and hippocampus. So what does this result in? These neuroplastic changes, what happens? So we have impaired executive function. So we look at the front part of our brain, kind of tells us what's good, what's not good, what's a good decision, maybe I shouldn't do that. When we're under the influence of many substances, that might be one of the first things, we've maybe encountered, we've seen our friends encounter them, but it happens where, maybe people are doing more risky things, doing things that they wouldn't normally do, not under the influence. So that's the front part of our brain that's impaired at that time. Diminished self-regulation. We're not able to maybe cut back, we're not able to stop or slow down our drinking or our substance use. And then increased compulsivity. So being more compulsive, doing things that, like I said, we wouldn't normally do, not under the influence of a substance. And then this, of course, as our brain starts to change and as these substances change the structures, the chemical pathways in our brain, we stop having that awareness that what we're doing might be negative and it might cause problems for us. Mental health disorders. So just looking at, what goes on in our brain, we also know that that's a chemical imbalance in our brain, right? So we look at dopamine, glutamate, stress-related neuropeptides or neurochemicals, such as corticotrophin releasing factor, and that contributes to both our mood disorders as well as our anxiety disorders. And looking at kind of the big picture, we have genetic factors that go into play. We have developmental, and then also our environment. So how you're born, that is set, right? Our genes are our genes, and there has been a lot of studies to show that a lot of the factors of addiction and mental health are genetic. So if we look at our family history, that's really important for us, right? One of the things I ask a patient every time I see them for the first time, I always ask about family history because it's so important, right? Bipolar is probably one of the strongest that we see. Also schizophrenia, but depression, anxiety, there's so much of that genetic component. And then how we grew up. So did we reach our developmental milestones growing up as a kid? Did we have any problems with nurturing and, getting that love from like our family members and the people around us? Were we cared for? Did we have those basic needs of living growing up? Did we have food? Did we have shelter? Did we feel safe, right? So those are three really big factors that contribute to how we grow up and how that affects us when we get older. All right. So here's a picture I was talking about. I'm glad it's so big. This is the biggest presentation screen I've ever seen. So that's fantastic for you all. I was worried it wasn't going to be big enough. So here you can see kind of some of those parts that I was referring to earlier. So I found this explanation of addiction cycle in like these 3 stages. So it's pretty easy to kind of narrow it down and make this a little simpler. So at the top, we look at our incentive salience. So binge intoxication, this is how it starts, right? We start with a stimulus. A stimulus is the drug or, the substance. We look at our reward pathways in that. So kind of this activated stimulus in our brain, and then kind of affecting the basal ganglia and reinforcing that drug use and that cure-driven craving. So that's kind of where we start. Once we kind of go to, step 2, as you look further down here, we look at the withdrawal and the negative effects. So this is our stress, our emotional circuits, and our amygdala, and this becomes hyperactive. So this can lead to a lot of our anxieties, our fight or flight moments, right? And then our depressions, irritability, which is also a big one. And then this kind of, because of those things, then we're more inclined to use substances to push down those feelings, right? If we're feeling irritable, if we're feeling upset, if we're feeling anxious, okay, well, that substance, that stimulus before, that made me feel better, so let me keep doing that. And then we kind of come to our third one, which is the main craving. So the prefrontal cortex, like I said, that's our executive functioning in the front of our brain. That dysfunction impairs our decision-making capabilities and also kind of continues to affect our high relapse risk in the future. So with these brain changes and these neural pathways and the chemicals that we see being changed by continuous exposure to that substance, we see changes down the line. And that plays a huge role in our patients, right? This isn't something that we can, blood pressure, for instance. We can't just throw a medication at them and be like, okay, you're good to go. It's fixed, blood pressure is down, good to go. No, this is a continuous pathway, a continuous issue that our brains see and our brains change. All right, so kind of going into what does it mean to have a substance use disorder, right? What does that even mean? And I know the different terminology over the years have changed, right? So we used to say, people were addicts, right? We used to use these kind of negative connotations. I know at AA, everyone stands up and says, hi, I'm so-and-so and I am an alcoholic. So we're definitely kind of past that stage in medicine now where we don't like to label our patients or people with the disease, right? We like to say, you are struggling with a disease, so let us help you. And let's say, for an instance, we don't call our patients addicts. We don't say, even the term addiction sometimes can be very stigmatizing. So, in the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders, which is pretty much my Bible as a future psychiatrist, we look at diagnosing substance use disorders. So this is the diagnostic criteria. So we need to have a problematic pattern of use leading to 2 or more of the following things. So take more or for longer than intended. So, I'll just use alcohol for an example for this. So let's say we're, maybe binging on a weekend and we're drinking, more than we intended to. Okay. So that happens once, right? What else? Is that, then it starts happening maybe 2 times a week, maybe 3 times a week. And then maybe it's not just 1 weekend a month. Maybe it becomes an every weekend a month as time goes on. So then we're kind of looking at, okay, maybe we're looking at a substance use disorder. But let's look at the other criteria. So the desire, effort to cut down or control use. So, maybe I'm looking at cutting things down, and then, I kind of feel like, oh, I don't want to miss out on something, let me go out. And then that kind of leads to more use. More time using, and recovering from it. So now my nights of drinking have turned into the next day of me being completely like incapacitated because of that use. And then craving, so craving that substance, whatever it be. Results in repeated failure to fulfill role obligations. So now I'm sleeping in later, I'm not coming to work. Maybe, if I was a mom, I'm not able to get my kids to school on time, or not able to do the things that I normally love to do for them. And then results, continued use despite recurrent problems due to use. So maybe that's that part where we don't see, the person who's dealing with that disorder doesn't see the problem that they're having on the people around them, or in their jobs, or with their kids, their families, their friends. Reduce important activities due to use. So, now I'm not showering, I'm not eating right. Maybe I'm not, going to my support groups or my therapy or my doctor's appointments. Recurrent use in physically hazardous situations. So that's kind of looking at maybe driving under the influence, or being in a situation where, I could cause harm to myself or to other people. Tolerance. So maybe instead of, 2-3 shots, it's now 10 plus. And then withdrawal. So having those symptoms of, I haven't, I'm using alcohol for this whole experience, but it happens with everything, right? Is, you're feeling now the side effects of not having that drink, or now you have to have a drink when you wake up in the morning because you're starting to feel tremulous, you're starting to have anxiety, your heart's racing, things like that. And then, of course, we have different classifiers, different ways to classify the substance use, so mild, moderate, or severe. And that is how we diagnose somebody with a substance use disorder. And it's not as simple as I wish it seemed. All right. So what is dual diagnosis? So this involves a simultaneous presence of mental health and substance use disorders in one individual, okay? Pretty straightforward, right? We've got two things going on, and that complicates treatment. Challenges in diagnosis and treatment. So each disorder can worsen the other. Like I said earlier, is it the chicken or the egg kind of thing? Like, what is happening? Is one, causing the other one to be worse, or are we medicating to kind of lower the anxieties that we have every day? And then integrated treatment approach. Challenges in diagnosis and treatment. So each disorder can worsen another. That's what I just got talking about. Sorry, guys. Integrated treatment approach. Effective management requires a coordinated approach addressing both disorders simultaneously, which is what I'm going to talk about. So this is kind of looking at, all right, well, if we just treat maybe someone's depression, then everything else should get better. I don't know. Or maybe if we just treat the substance use, maybe the depression will get better. I would like to say yes, that happens, and I think it does, but I think we have definitely some more room to improve. So, and I'm sorry that this got cut off a little bit. Clinical complexity of co-occurring disorders. So we look at the complexity of a dual diagnosis. So we have the mental health side of things, we have the substance use disorders, and that overlap. And I think we're in the time now where we're seeing more resources for these patients, and we're getting to see that there are more dual diagnosis programs out there for these patients. But how can we start making the treatment in general better for these patients? Medication management. So I know there's a ton of people that I'm thinking of, oh, this would be a great medication for your anxiety, let's say. But then maybe they have a co-occurring alcohol use disorder. And maybe that medication that I wanted to give for anxiety is also more of a downer, let's say. Well, we can't really, prescribe something that might help them a lot with their anxiety, But then also, let's say if they're drinking alcohol, that's dangerous. We can combine those two downers and then can, lower people's respiratory rates. It can also cause death. So we have to be really careful in making sure that when we are prescribing medications that we can talk to the patients hopefully about their use disorders and see about, do they use any kind of substances, any kind of nicotine. I know a lot of us ask do you smoke? But nowadays it's like, do you vape? Right? So it's a big, changing, evolving world of medications and also substances. And so kind of going back to that integrated care approach is what we'll get into more. All right. So integrated treatment models for dual diagnosis. So we're looking at places, people, things that are very educated and will be able to kind of give both of that, that treatment to the patient, both the mental health and the substance use. We look at therapy components. So that's one of the, best things that we have is therapy and CBT, cognitive behavioral therapy, motivational interviewing, assertive outreach, and culturally competent care. So different things that we can use, we can implement into our practice with our patients to really help them. And then how do we support them too in their recovery? So kind of looking at maybe plans, different recovery plans that we can make with our patients, and also getting them set up with community supports, right? So that's how we can help them as much in like a clinical setting in the office, but what happens when they leave? What happens when they go back out and they're back in that environment where maybe their friends, their family, everyone they knows is also dealing with substance use. And then implementation and stability. So looking at our models of organizational change, which I will get to in a little bit, and looking at, how can we educate, each other as if you're a clinician, if you're a community member, if you're a family member, or if you yourself are struggling with any kind of substance use disorder. How can we train each other and give each other, that support that we need? All right, so biggest thing I would say is that team-based approach. So that's one of the first reasons why I even got into psychiatry, because first day on the unit, I remember I was in medical school and I come to the psych, floor on the inpatient side, and we sit down and we sit in a meeting. And it's the doctors, it's the nurses, it's the case managers, it is everybody in one room, and we talk about each individual patient. That is team-based approach. We have a multidisciplinary team who comes together and makes things happen for our patients. That is really awesome. So, we have that in the inpatient side, but we also have that in the outpatient side, right? We have our therapists, we have our psychiatrists, we have our community-based supports and our recovery specialists and our peer specialists that all kind of come together, and we want to make sure that we keep that communication line open, because that's how we're going to be able to support them in all environments. And of course, studies have shown that this approach leads to better treatment results, fewer hospitalizations, and greater housing stabilities. So, it's not just your patient when you're in the room with them and then they leave and then that's it, you forget about them. No, it's, going out into the world. That's how we can keep, our patients safe and keep, this patient population from having lower risks of relapse and, hospitalizations and death. Personalized treatment planning. So I think this is kind of interesting because I feel that the whole, healthcare system is kind of going towards more of like this individualized plan and care model for a lot of people. So that's something too that we can help improve and definitely go forward in the future. So our treatment options. So we use a lot of different medications. Most of them, right, all of them are FDA approved. We do use some medications that are off-label, as we call them. But I'll kind of talk about, what the mainstream FDA approved medications are. So looking at first opioid use disorder. So we have, of course, we have buprenorphine, we have methadone, we've got naltrexone. This reduces the opioid use, improves retention, decreases mortality. We've seen it time and time again. And I'm, really happy to kind of see the evolution of that initial stigma with these medications as they first came out, and now seeing, that stigma kind of being, it's still there, it's still present, but I definitely can see that more people are open to these things than they were when they first came out. And it's proven, it's fact, it's evidence that these medications save people's lives. All right, and then alcohol use disorder. We have naltrexone, acamprosate, and disulfiram. Well, we mostly use naltrexone, I've seen more recently. The other medications, especially disulfiram, cause a lot of side effects, let's say. So they're not tolerated really well by patients. But we do use naltrexone quite a lot. And this has shown to help with cravings and has shown to help with decreasing the alcohol use in this population. Tobacco use disorder. So of course, I think like everyone remembers like Chantix back in the day. I remember like the commercials for it. We don't really use that as often anymore, but we can use Wellbutrin or bupropion, and then of course nicotine replacement therapy. So that's, I always say everyone in my family that struggled with tobacco use disorder and smoking, I don't know personally, but it seems like a very, very difficult substance to get over. So that one definitely, it's very prevalent. I feel like we don't really even think about it as like a substance use disorder a lot of times, but it is. And it can affect a lot of the medications we use, both psychiatrically and on the medical side. And then stimulant use disorder. So there's really not an FDA-approved medication that we typically use for these patients. When I was doing research for this presentation, they talked about the bupropion and the mirtazapine, so Wellbutrin, Remeron. But really, it's going to be a lot of therapy. It's going to be a lot of, looking at maybe any kind of like mental illness that's going on at the same time to treat these patients until we get something better. And then, like I said, patients that have severe mental illness, so we look at, kind of the spectrum of different psychotic disorders and both mood affective disorders, and we see that, certain medications can be better than others in certain populations. I know, our SSRIs are our like tried and true. They're great medications to use for depression and anxiety. They take a long time to start working, right? Like these medications can take, we say 4 to 6 weeks, and I see that, So we need something, and making sure that we're not missing anything for those initial, 4 weeks when people are started on these medications. So we need to use adjunctive therapies as well, which is very important. All right, and our behavioral interventions. Like I said, cognitive behavioral therapy is fantastic. So that is, what I look forward to hopefully doing in the near future with a lot of my patients. But it is first line for most substance use disorders. We, a lot of times, will use it adjunctively with medications. A lot of the randomized controlled trials in the past have said that combination of both medication and therapy is the best thing, right? So looking at what we can do for that patient population. CBT targets maladaptive thoughts and behaviors and skills for relapse prevention, which has been shown, to be the best type of therapy for this patient population. We've got motivational interviewing, so we engage with the patient. We kind of, see that readiness to change, where they are on that spectrum, but also give them kind of that tool, give them the tools, to put in their toolbox to help them process where they are and how to get them to the next step of their recovery. Contingency management, so this is like positive reinforcements. So, giving them something to help them not to use, and kind of giving that positive reinforcement, reassurance as time goes on. And of course, 12-step. This is the one that I'm most familiar with, but this is, our support long-term recovery. So in the outpatient setting, in our community settings, there's a ton of different resources for AA. And it's cool to see too. It's not just, a lot of people are kind of like, AA can be stigmatizing too, right? I feel like even for like the younger population, like, oh, maybe I'm not very religious and maybe that, will prevent me from going to like AA. Well, there's other programs out there, there's different things. And I think AA is really tried and true to say that you need that higher power, whatever that is for you, and I love how open that, that program is. Integrated care. So this is for both substance use disorder, mental illness, and treating both conditions. So looking at what we have for them in the community and what programs are there for them. All right. Special considerations for comorbidities. So assessment and treatment should be integrated, not sequential. So looking at different outpatient offices. I know over one of our offices in Broadhead, we have psychiatry team, but we also have alcohol and substance use counselors there as well. So we can, set them up with both simultaneously, and that is how we kind of target multiple things at the same time. Clinical guidelines and emerging trends. So I'm kind of going to go through each one of these one by one, but we have certain guidelines. We have tip 42, which I'll go through on the next slide, of giving us kind of a framework for managing these patients. Models of integrated care, which there's a few, and I'll get to those in a little bit. The no wrong door policy, and individualized treatment and monitoring. Again, I'm sorry that cut up at the top and the bottom here, but it says it's the Substance Abuse and Mental Health Services Administration. So they kind of give us different guidelines on how we can treat patients and improve our outcomes. So this is tip 42. This is the comprehensive guideline for how to treat co-occurring mental illnesses in patients with substance use disorders. They look at different evidence-based recommendations, so different screening tools that we use in the outpatient setting or inpatient, assessment tools, and then, of course, our diagnosis guidelines and our integrated treatment for these co-occurring illnesses. And looking at the different importance of the coordinated patient-centered care, right? So that's the most important part, is that our patient and our person is at the center of the care, making decisions, being able to be a part of what they want, right? It's definitely up to them and the level of care and what they want. So kind of goes over some principles of integrated treatment, care coordination, strategies for engaging and retaining individuals with co-occurring disorders, use of pharmacological and behavioral interventions, approaches for managing complex cases and addressing social determinants of health, and guidance for program administrators and clinicians on workforce development and implementation. So we use this widely. I look forward to working more in the substance use disorders, as an outpatient resident in the next couple of years. But, this is something that we have as a guideline that we can reference to kind of help us navigate our way through these difficult cases. All right, looking at now our integrated models. So I feel like, the collaborative care model is a very common one. The American Academy of Addiction Psychiatry highlights the collaborative care model. So as team-based, which I already talked about earlier, a structured approach with a lot of evidence. So 90% or 90 randomized controlled trials have showed outcomes for depression, anxiety, and substance use disorders in primary care settings, that this has been a really fantastic way to go forth with dual diagnosis treatment. The Summit trial was one of those studies, and that focused on the collaborative care model, and it pretty much showed increased abstinence rates for opioid and alcohol use disorders, and also with a lot of cost savings for healthcare. And then we have the co-located and coordinated care model. So there's been a lot of different reviews on this. This isn't as robustly, researched compared to the collaborative care model, but it has shown that co-locating mental health and substance use services are associated with a reduction in substance use, mental health symptom severity, emergency department visits, and health system costs. And then integrated behavioral interventions. So studies have shown that CBT, motivational interviewing, those are kind of the big ones when it comes to treating these patients with co-occurring illnesses, especially with alcohol use and PTSD, interestingly enough. And then looking at like the combination of psychopharmacology and what we can do for our patients from a medical standpoint as well. All right, so this is kind of just like my little background of what I've personally seen and what I've experienced since coming to St. Luke's. During our program as a resident, we're able to, our third year, go to a primary care office. We can go to an OBGYN office. We can do community psychiatry with parish nursing over in Allentown during our third year and our fourth year. And we implement that into our outpatient schedules. So we rotate through these places and we're able to provide, psychiatric care, whether that be in a PCP office or out on the streets, doing street psychiatry. Which is really an awesome opportunity. And then also we do a lot of education in that setting too. So helping our PCPs, helping our community workers, be able to recognize, crises or be able to see, okay, when a patient actually needs maybe a higher level of care and what to do next for them. The next thing that I've been seeing and I've been working with is this one-time consult research project that we have going on at St. Luke's. So we're currently serving 8 different PCP offices there within the St. Luke's network, and we're allowing them to put in for a one-time consult. So a one-time consultation with a psychiatrist to give recommendations. So this can be, somebody, let's say, who's been on the wait list for like 6 months, their primary care doctor has tried multiple different medications for them. It's just not cutting it. Maybe they have, they're, an AA, but they've been really struggling with their cravings. Let's say they're also really struggling with their depression and nothing is helping them. Okay, so until we can get them in to be seen by their, psychiatrist, that might be however long that takes on the wait list. Let's get them in for a one-time, full-blown consultation by a psychiatrist to give their recommendations. And these recommendations aren't even just like, oh, try this next. It's like, try this. If that doesn't work, try this. If that doesn't work, try this. And that communication is huge with this project. So, providing the PCP with information and then also having them be able to ask any further questions and follow up. And then, of course, the PCP will take them back until they, can be seen by a psychiatrist in the future. And then emergency department crisis rotation. So this is something, too, that we do mostly over at the Sacred Heart location in Allentown, that we're seeing patients that are, in crisis coming into the emergency department for a psychological evaluation. We work really closely with the crisis workers there in the emergency department. We also work with any kind of attending, so whether that be from the medical side, be from the psychiatric side, we kind of are the middle person there trying to see what the best level of care would be for this patient. And then, of course, our consultation services at Anderson and Sacred Heart, right? So psychiatry, we try to integrate into outpatient and inpatient services. So on the inpatient side, I see a lot of different consults over at Sacred Heart, specifically on like the detox floor that we have there, the withdrawal management floor. And so that's, integrated care right there, is being able to have a psychiatrist come in, do an evaluation and see, does this patient need higher level inpatient psychiatric care? Or do they need inpatient rehab? Or do they need dual diagnosis centers? And being able to kind of figure that out with the patient and figure out what they also want and what would be the best. All right, so this is just a quick, I don't know if you can see, okay, good. So this is just a quick, breakdown of different care models and how they've shown to decrease relapse rates and also improve the psychiatric side of things. So as you can see, they've really all got positive results. So I think this is the direction that we're heading as far as future healthcare. All right. And the no wrong door policy. So this is something that I don't think, people know that that's called like the no wrong door policy. I think it's something we implement all the time. But this is people that can access care for either condition at any entry point in both the health or social service system. They should be welcomed, assessed, and connected to the appropriate treatment. So regardless of where they first seek help. So like in the emergency department, someone comes in, we see a lot of people who maybe need to do withdrawal management first or detox, and then go forward to inpatient or outpatient rehab services or dual diagnosis or inpatient psychiatric services. So that's where we see it a lot, the emergency department. But then, of course, someone comes to the county courthouse and they, are asking for help. Okay, well, let's get you to the closest emergency department so that you can be further assessed. Coming into outpatient services, so your psychiatrist, your PCP appointment. Okay, what can we do to get you to where you need to be? So key elements of this: admission criteria should not exclude the patient based solely on the presence of a co-occurring disorder. This is huge, right? The stigma is still out there whether we like it or not. Someone comes in acutely intoxicated, they, let them, kind of go through this on their own, make sure they're safe, and then we'll see what's up. There might be a lot going on. There might be a lot of different depression going on. Maybe this was a suicide attempt, and we just have to wait and talk to them and make sure they're safe until they can get to a point where they can talk about what they need. So lots of different things there, but I think it's so important for us to keep an open mind, whether we're seeing these patients in clinical settings or community settings, to make sure that we're not just, labeling them or looking at them like, oh, they have, a problem with this substance. Of course, our education is huge, so making sure staff are trained to recognize and address these. So like I said before, it's all about communication. We're working with the PCPs, we're working with the crisis workers, the community, street psychiatry, street medicine providers to be able to recognize and address what these patients need. And then care coordination and referral networks. So how do we get them to the next steps? How do we make sure that these patients, get to where they need to be? Even if it's something like getting their prescriptions from their pharmacy, something that can kind of ensure that next step is being addressed for these patients. And this idea of individualized futures, right? So making sure that we're not just stamping the same thing on every single person. We have to try to see, okay, well, maybe that worked for that person, but maybe it's not going to work for this one, right? So different things that we can implement, and whether that be medications, digital health interventions. So that's huge now, right? The telemedicine, telehealth. I know a lot of, patients I've worked with don't necessarily have computers or internet too. So even getting them set up with certain resources, like going to a library or going to places that have Wi-Fi or network connection, that they would feel comfortable being able to do their appointments. Practical strategies and challenges. So we're wrapping things up here. So just a couple other things that we keep in mind when we're looking at patients, and people with multiple things that are kind of contributing to their current state of mind. We want to make sure that we're looking at them as a whole. We have this holistic approach, but we also have different supports. So, a lot of times people come in and they don't have family in the area, or they don't have any friends, or all their friends have passed away. And it's getting them locked in with other ways to support them in the outside community and in the immediate time frame. Lifestyle modifications, of course. So, lifestyle medicine is huge and it's upcoming, and I think that's a wonderful thing, especially in the realm of psychiatry. Most of the serotonin in our body is in our gut, believe it or not. So what we feed ourselves sometimes contribute to our worsening depression and anxiety, which has been proven. We don't think about that a lot. So what are we feeding ourselves? What are our patients eating? How can we provide them with, the education and support to help them in different modalities? Meditation, yoga, art therapy. I know there's a lot of different apps now. YouTube has been great. I'll recommend a lot of meditation to patients just to start with. There's some very simple, very quick ones out there just to get people going. And then as, they start to really enjoy this, start to get more into the meditation side of things, there's more programs that they can do. Of course, we know the barriers. So I've been bringing up stigma a lot during this, but I think it's something that we as a whole, as a community, have to continue to fight the stigma. These disorders do not discriminate with anybody. So it's out there. It's people that we know we work with every day, our friends, our family members. Sometimes we don't even know that they might be struggling with something. And so just keeping, doing our due diligence and making sure that we're supporting one another and we're being kind. Our healthcare systems, we've made it this far where I think we're definitely in need of a lot of change still, a lot of growth in our healthcare systems. A lot of services still need funding and unfortunately have been losing funding, but I think that in the future we'll be going in the right direction. And then, of course, our limited access to treatment. So I grew up in very small town. We didn't even have a psychiatrist in the town. We'd have to go to like Wilkes-Barre or something to see a psychiatrist, or Scranton. And even then, there'd be like one psychiatrist for everybody. So I think around here we have wonderful access, but at the same time, our wait list, I think, is, someone said, like 11,000 for St. Luke's to get to see a psychiatrist. So we definitely have a lot more growth and a lot more access to achieve. And of course, our insurance barriers. I could do a whole presentation just on that. All right, I'm wrapping things up, everyone. So like I said, we kind of went through like the integrated multidisciplinary care for these patients and how important that is to treat the whole person and to not just treat one thing or the other. Ongoing research right now, which is I'll get to on the next slide, and policy and systemic reform. So, working with our local representatives and making sure that, if there is something that we need to support, or if we're not in support of something, we're communicating that with our government officials. So this is just a little bit of like recent research topics in substance use disorder. So we have, again, like that personalized treatment we're looking at more and how that affects people, looking specifically at genetic testing and even AI to match medications effectively, which is really cool. I've seen a little bit of the genetic testing, and it's been interesting to see like, oh, that medication doesn't do anything for you, so let's try this one that does. Holistic approaches, so integrating like yoga, acupuncture, mindfulness, meditation to help manage withdrawal symptoms, and definitely seeing that implemented into more inpatient rehab facilities. Trauma-informed care, so PTSD, anxiety, depression, looking at the root cause, right? Going back and doing trauma therapy, trauma care for these individuals. Telehealth integration and what that will look like for patients struggling with addiction. Different medications, so we're looking at MAT, so medication for addiction treatments, but then also looking at, I know we have injections now once a month. We've got different opportunities out there. So I definitely think that will continue to grow in the future. And then the GLP-1s, which have been really on the news recently. These are like our semaglutides. People think of like Wegovy or Ozempic. But actually, these medications are doing a lot more than what I think they intended to do as far as clinical trials right now. It's still too early to say, but there have been some trials and some some evidence to say that these medications could help with cravings and could decrease the amount of substances used. I think the one study looked at alcohol in particular. And then self-compassion interventions. So, this is to kind of look at the patient and help with those coping mechanisms and being able to help them with their recovery. All right, I will take any questions. Thank you so much.
Yeah, I had a boyfriend that passed away from addiction.
I'm so sorry.
And the hospital that he was at, the Valley, it was a physician assistant that he went to, did not do anything to take care of him when we went back to the doctor. So he passed away.
I'm so sorry. I'm so sorry to hear about your loss. Thank you so much for sharing. I think we have a lot of growth that needs to be done. And it starts with people sharing their stories and making change for the future. Absolutely.
When people initially get diagnosed, let's say for mental health and are currently in an addiction phase, do you think once the addiction phase is not resolved but controlled,
Mhm.
should they be reevaluated for their psychiatric disorders?
Absolutely. I definitely think that psychiatric evaluations should be done every time you're seeing a patient. There should be, an evaluation of their diagnosis, because diagnosis can change. Absolutely. And we have a diagnosis that we use a lot of times when patients are acutely going through their substance use, withdrawal or their use periods, and we kind of label it as substance-induced mood disorder. So until, if we're labeling someone with that, we like to see that their use gets into control, and then we'll evaluate them again and see, is this an ongoing, recurrent, major depressive disorder? Is this, a dysthymia, so someone who has depression for years at a time? Or, is it a bipolar disorder? A lot of people that come into the hospital who, we kind of label as, they're in a manic episode for bipolar disorder, but they've also been utilizing, let's say methamphetamines for the past, few months. That's tough. It's really hard to figure out, well, what happened? Was it the primary mental health disorder that caused their manic episode, or was it the methamphetamines that induced this mania? So I think that reevaluation is crucial. I think that because of the stigmatized language of different disorders, that I personally, when I'm seeing a patient, I don't like to label them with, a bipolar or a schizophrenia or something that I think maybe was substance induced. So I'll put either substance induced or I'll put unspecified, and then until we can clarify it more as we learn. I can hear you.
piggyback on what he said earlier. In 1985, my son was hit and killed by a car. And when they closed that lid on his coffin, I lost my mind. And some days I think I still haven't found it. But I went in the rooms of NA, that's my church. Someone introduced me to a drug that I'm not proud of. But today I have over 15 years clean. But my problem today is, thank you, nicotine. And I said, I go to adult daycare. So I got off the van yesterday and I asked this lady, could you go down to the gas station and give me a pack of cigarettes? She said, no, Olivia, I stopped smoking. I said, how many days? She said, I have 2 weeks. So I said, well, I asked God and pray for me. So I had 2 cigarettes this morning. I smoked one. Before I got here, I hauled my butt down to that gas station and got me a pack. That nicotine is a boogie. That's my addiction today, those cigarettes. It's a boogie. Uh-huh. But a drug is a drug is a drug. Uh-huh. Yes. Yeah. And my primary care, not to cut you off, my cardiologist, they get on me about it. Have you stopped? I'm like, no, but I try. But every chance I get, I'm like that Indian standing in front of the store. I'm puffing. I'm trying, but I'm bipolar, manic depressive, they said, but I'm not that bad. I take my medication as prescribed. I used to fight it. I remember the first time I was 302. I didn't understand it. You know, they 302'd me because I chose to try to take my life because I wanted to catch up with my son and whatnot. But this Sunday was my birthday, and all my family members are deceased. I'm the last one in my family lived. No one ever lived to see 69 in my family. But through medication and prayer, I'm here today. You know, and I don't try to take my life, but those cigarettes are a boogie. A drug is a drug is a drug, and I have no use for street drugs at all, none. So it does. If you take your meds as prescribed, you're all right. I'm okay today. I really am. Thank you.
To self-medicating on most people's part, I think, one type of medication or another, and then when you become addicted, you create so much more PTSD. You destroy your life. You go through hell. You're scared all the time, and then what do? It becomes a cycle that you got to get out of. You need a whole special type of therapy, yeah, just to deal with that type of deal, uh, the dually thing where you have both. It's horrible. And then if you're in rehab and you ask people, they didn't have it, they got it from what they did. They blew their lives right out of the water. Then they have to